Hi everyone, my name is Jessica Collinsworth and this is my case study presentation on pelvic inflammatory disease. First, we will begin with a brief overview of pelvic inflammatory disease. Pelvic inflammatory disease, or PID, is inflammation caused by an infection in the upper female genital tract above the cervix. The severity of symptoms of PID vary greatly from patient to patient. Patients may experience mild to severe abdominal or pelvic pain, abnormal or different vaginal discharge, fever, vaginal pain or bleeding during or after sex, or dysuria. The inflammation and infection can eventually spread to the uterus, to the fallopian tubes, ovaries, into the peritoneal space, and even cause inflammation to the lining of the liver. Since the symptoms of PID vary greatly, subclinical infections can occur, and the long-term inflammation to the reproductive tract can cause women to be unable to have children. Although there is no gold standard, the diagnosis of PID is often done based on the patient's presenting symptoms, including fever, vaginal discharge, and complaints of uterine, adnexal, and cervical motion tenderness upon pelvic examination. If PID is suspected, treatment should not be delayed while waiting for the return of more confirmatory diagnostics, such as chlamydia or gonorrhea or wet mount swabs, CBC, ESR, or CRP levels. It is important to recognize that sexually active women under the age of 25, especially those who became sexually active early in life and have had many sexual partners, are at the highest risk of developing PID, especially if the patient has had PID in the past. Although barrier-type contraceptives prevent the transmission of most STDs, the most recent data shows that oral contraceptives and IUD birth control methods do not increase the patient's risk of developing PID. Lastly, PID is the cause of over 100,000 outpatient visits and 600,000 hospitalizations annually in the United States. Next is an overview of the pathophysiology of PID. Once again, it is an infection causing inflammation in the female genital tract above the cervix. About a third of the cases are known to be caused by chlamydia or gonorrhea, but a total of 85% of PID cases are caused by sexually transmitted infection pathogens through sexual intercourse, while around 15% are caused by bacteria found in the intestines via pelvic or abdominal trauma, surgery, or disease processes affecting the intestines. That being said, about 35% of cases are caused by more than one pathogen. It is also important to remember that although PID is less common in pregnancy due to the formation of the mucus plug around 12 weeks, PID can still occur before the mucus plug forms. The long-term complications of PID include recurrent PID episodes requiring treatment, infertility from the damage caused by the inflammation, hydrosalpinx, which is the fallopian tube becomes so damaged from inflammation that it becomes blocked and fills up with fluid, therefore eggs are unable to pass. Although it is just the fallopian tube that is damaged in this condition, patients with hydrosalpinx also often have poor outcomes with in vitro fertilization as well. Chronic pelvic pain may also occur, possibly from the scarring or adhesions that were left from the inflammation. Now that we know the basics of pelvic inflammatory disease, I will present a fictional case study. Good morning. Today, our first patient is a walk-in complaining of lower abdominal pain. She is a 21-year-old female complaining of 8 out of 10 constant aching pain in her lower abdomen for 3 days. She also said she has had different vaginal discharge since last week. She described it as creamy mucus. She also reports light spotting in her underwear today, which prompted her to come in since she had her period 2 weeks ago and she's on the birth control pill. Most of her health history seemed insignificant, except she said she had a newer male sexual partner. She said she has had 5 previous partners and reports pain sometimes during intercourse. She also said she has had 1 elective abortion at age 16 and she started having sex when she was 14. Her vitals are stable, but she does have a temp of 101.4. Her physical exam seemed normal, except for when I did her pelvic exam, I noticed the cervix was red, and I saw some mucopurulent discharge at the os. The entire bimanual exam was really painful for her. At this point, I'm thinking pelvic inflammatory disease, but let me run through the differential diagnoses to be sure. Her urine HCG was negative, and she hasn't missed her period, so I don't think ectopic pregnancy is the issue. Ovarian cyst tension could be a possible cause for her pain, but her pain didn't start suddenly. I don't want to delay her treatment if it is PID, but maybe we can make a note to order an ultrasound if the antibiotics don't curb her symptoms. Cystitis isn't likely as she hasn't had any urinary symptoms, and her in-house UA dip was normal. I don't think it's appendicitis because the pain isn't localized to the lower right quadrant, and she isn't vomiting, and the psoas and obturator signs were negative during her exam. I also don't think it's diverticulitis or IBS at this point because she doesn't seem to be having any GI problems. Since we both agree that the patient is more than likely suffering from pelvic inflammatory disease and she doesn't have any allergies, I think we should give her 250 milligrams of Rocephin IM now, and then we'll send in a prescription for her for 100 milligrams of doxycycline for her to take twice a day for 2 weeks. I also think we should send in the PAP, HPV, chlamydia, gonorrhea, and wet mount swabs I collected during the pelvic exam. And we should also have the MA draw some labs. I think a CBC, a CMP, ESR, CRP, syphilis, RPR, and HIV will be a good start. It'll also be important to give her ER precautions should she suddenly feel worse. I'll also tell her to call the office if she isn't getting better over the next few days so we can reevaluate her situation. Otherwise, we'll see her in 2 weeks.